Hi, good morning, all, and welcome to this meeting of the Primary Care Access Delivery and Payment Task Force. This is a meeting of the Workforce Workgroup. I'm David Saltz. I'm the Executive Director at the Health Policy Commission and proud co-chair of the Primary Care Task Force, here today to help co-lead this conversation with my colleague, Dr. Ryan Schwartz from Mass Health. We're here today to engage in a robust conversation around care teams and how they can help support primary care. It's great to see everyone here today. Thank you so much for continuing to participate in these lively and impactful and meaningful conversations. And thank you for everyone who is tuning in on the live stream. Your continued engagement is really valuable as we continue this important work. So I'm going to turn it right over to Ryan to introduce our agenda and provide a few opening introductory remarks.
Thanks, David, and good morning, everybody. Thanks again for joining us today and for all of the time and effort that everybody is putting into this task force. Really looking forward to today's discussion. So we had circulated a number of potential topics to focus on over the coming month to this group, and given kind of the feedback that we got, today's discussion is going to focus specifically around supporting team-based care and behavioral health integration in primary care. Our hope is to use this discussion, as well as some future discussions and meetings that we'll have in the coming months, to further inform statutory deliverable 7, which, to remind everybody, is to create a short-term and a long-term workforce development plan, as well as statutory deliverable number 4, which is to propose payment models to increase reimbursement for primary care. However, before we dive into our discussion today, first order of business is to approve the minutes from our last workforce workgroup meeting, which was on November 18th. So we'll do that quickly via roll call. When I call your name, please just vote yay or nay. But before we hit the roll call, any amendments to the minutes? And if none, I will call for a motion to vote. Any amendments? Okay.
Motion to approve.
Second.
Thank you very much. I will quickly go through the roll call. Please vote yay or nay when I hit your name. David Saltz.
Yay.
Wayne Altman.
Yay.
Brenda Anders-Pring.
Yay.
Laura Black.
Yes.
Jennifer Blewett. I think we said Jennifer is not here. Is that correct? Yeah. Okay, we'll keep going. Allison Bracken.
Yes.
Renee Cruchlow.
Yes.
David Gilchrist. Don't see David.
No, he's not here.
We'll keep going. Stephen Martin.
Yes.
Christina Severin.
Yay.
Barbara Spivak.
Approve.
And I also vote yay. And with that, I believe our minutes are approved. David, I'll turn back over to you.
Great. Thank you, Ryan. So before we dive into the discussion today, I did want to just introduce one of the additional participants in today's discussion that we've invited. She's probably well known to many of you, but I just wanted to introduce Amy Doyle. She is the director of the Behavioral Health Workforce Center here at the Health Policy Commission. This Behavioral Health Workforce Center was established about a year and a half ago, 2 years ago, here at the HPC, in partnership with the Executive Office of Health and Human Services. And Amy has been leading this effort. Her team is responsible for conducting a number of different research studies into the behavioral health workforce. One of the first legislative mandates and one of the first studies is going to be released really soon. And it's really examining behavioral health payment rates in Massachusetts and commercial payment rates. And we're excited to be able to release that. Prior to joining the Behavioral Health Workforce Center at the HPC, she was the Deputy Director of Policy at Mass Health for accountable care and behavioral health. And she helped with the implementation of the Mass Health ACO and MCO programs. And she focused on primary care, behavioral health, health equity, and health-related social needs programs. So we thought it was helpful to have her participate in this conversation, as she's been really thinking a lot about the behavioral health workforce, their needs, how that how we can think about integrating them into the primary care setting. And so welcome her to today's discussion. To just dive right into some of the content that we want to talk about, I first wanted to, as we often do in some of these conversations, just talk a little bit about what is being proposed in some of the legislation that is out there and being debated and considered by our state legislature. So I'll just spend a minute on just this one slide. I'll just say the current primary care proposals that are currently under consideration, they all really do talk about and really consider and support the concepts of team-based care and behavioral health integration. Although I will note that they don't really go into a lot of depth or specificity about what exactly that means and how exactly that's going to happen. So I will say all three of the bills do designate integrating behavioral health with primary care and, quote, employing community health workers or health coaches as part of the primary care team as qualifying investments that would make providers eligible for enhanced payments under a proposed primary care capitation payment model. So we've talked at the last full task force meeting around this concept of moving towards a capitation payment model, subcapitation payment model for primary care, and the idea of enhanced payments for enhanced capabilities, and the bills reflect that idea and do say that again, integrating behavioral health care, employing different members as part of the care team is one of those qualifying investments for enhanced payment. Additionally, some of the bills set up a separate body within the Health Policy Commission, an advisory body to the HPC that include a member of the National Association of Social Workers, with a person with specific expertise in behavioral health care in a primary care setting. And two of the bills, Senate 867 and House 2537, both add a goal to this advisory body to quote unquote strengthen the integration of primary care and behavioral health and increase investment in behavioral health. So that's kind of the level of specificity that's included within the legislative proposals. So today we really wanted to discuss these concepts. What does it mean to integrate behavioral health care? What does it mean to strengthen team-based care with all of you and get your perspectives on this with the goal of maybe further clarifying some thoughts and priorities so that maybe we can, kind of further clarify our recommendations as we think about recommendations for our payment proposals in terms of, as Ryan said, deliverable number 4, as well as our kind of workforce recommendations, deliverable number 7. So that is really kind of the foundation that I just wanted to lay in terms of the legislative side. I'm going to turn it back over to Ryan and to spend a little bit of time just kind of talking about why do we think care teams are valuable, and want to share some thoughts with all of you from one of our PCTF members and open up for a little discussion about that as a level setting conversation as well.
Thanks, David. And I think I'll preface this by saying I think all of us have some component and capacity of experience with team-based care, and that varies across systems, it varies across practices. And so a part of, I think, our goal for this task force and as a part of this discussion and subsequent discussions is to hear from each of you what your experience has been, what works, what you have heard works, what you have heard does not work, and what you've experienced does not work. And also secondarily, and probably even more importantly as we look ahead, what is needed to better enable and capacitate practices to do this work and to build team-based structures like I think we all believe probably will add value for the patients that we serve, but it's not necessarily the current reality in many practices, if not the majority of the ecosystem. Before we open it up, and we do have some questions that we circulated, Stephen Martin circulated what we thought were some extremely helpful and insightful thoughts to a smaller group of us. So wanted to give Stephen an opportunity to share some of that with this group as kind of a prelude to our discussion today. Stephen, I'll turn it over to you.
Thanks so much, and it's great to be with all of you today, and I'm grateful to be on your team as we think about this. And Amy, thank you for all your work and those of your colleagues. Yeah, I was this is just meant to be sort of some context for our talk because we've all worked with wonderful team members throughout our careers. My first team member was one other person, was a nurse at a rural community health center who was also my sister-in-law. So things have changed over the past 20 years. We now have colleagues who focus only on prior authorizations, ones who call patients for colon and cancer breast screenings. We have scribes that are human and AI based. We even have inboxologists on teams. These are clinicians who remotely work on other clinicians' inboxes. And so these are all team members, but even these roles aren't enough. And there's enough work that others are creating for us and red tape that we need an unending number of teammates, it seems. And yet this kind of work is really a forced response to a broken system, and to my mind, and we're in desperate needs of solutions for those system problems because they're really breaking us. But I think that the teams that we're discussing today, and in general we think of, are ones that meet the needs of patients. And in this case, we have a prime example as integrated behavioral health. I really hope that can be our North Star, because it was a revelation to me when I arrived and had it at my health center 16 years ago. And in reflecting on what integrated behavioral health does, these are the four things that I think it does especially well. Reducing patient suffering, supporting the Starfield principles we noted in our definition deliverable. It encourages all of us to stay and enter the workforce because we have incredible colleagues doing the work with us. And I do want to just point to the fact that it does also reduce overall healthcare costs. And I don't think this is a superfluous reason. I'm including this because it really has become existential for the Commonwealth. We all care about our neighbors' health, and we have expanded Medicaid and Mass Health to do that, and have pioneered universal health care. But what's eroding our ability to take care of people are these ever-increasing costs. For example, in the proposed state budget, oral care for adults with Mass Health is facing cuts because of other increases. Our rural school district I've spoken of is in the proposed budget, has no school librarian and no curriculum leader directly because of healthcare costs. So that's one of our superpowers in primary care, is to lower costs. And I've done a deep dive in the literature, and yet there are surprisingly few studies of how primary care teams can, in addition to other important work, lower costs. And if there are others, I'd be grateful to know them. One way is to address, is noted here, ambulatory care sensitive conditions, and the other is to support continuity of care. Together with behavioral health, these specific uses are actually what patients want. They want care when they need it by clinicians who know them, and not have to go to the ER or be hospitalized instead. So in our very first meeting, I led with a Boston Globe front page story of a gentleman who was suicidal and in pain, who could not find primary care for 6 months. So I would just ask that our primary care teams must, at a minimum, be able to help him and so many others in a similar situation. And note that the Mass Health primary care tiering system is very thoughtful and in a similar spirit to these overall goals as well. So I hope these principles help us with why primary care teams are important, and then we can think about how and what. But I hope that the why comes first. And thanks. I hope this has been a helpful context.
Thanks so much, Stephen. Barbara, go for a comment, and then I'll transition to some questions for a broader discussion.
I think Stephen has laid out a wonderful rationale for what we need teams for. I don't believe that teams only include collaborative care. We clearly need social workers and nurse case managers to balance out a lot of the intensive work that many of us do. And that work occurs and is needed no matter what community you're in, whether you work in a socioeconomically challenged community or even a wealthy community. People need a lot of help, particularly people who are at the fringe, being elderly or, families. But I think one of the things we have to really consider is how do you pay for it? And the model of paying, and in the Medicaid ACO model, is a great model, except there's not enough money to do what you really need to do, to really hire the staff that you need. So, we've talked about increasing funding, and I'm not even sure that 15% increase is going to be enough. But it's a great start. We need to think about what does it really cost in today's world to put together the team that we as primary care physicians need to support ourselves. And Stephen is right. Those are supporting us help our patients. There's a whole other aspect of this that we need help supporting ourselves, trying to deliver the care that we need. For example, inbox management, which, takes us far longer than most of us would like. And, at some point, I'd like to also add in a conversation about what do we mean and what do we really need in behavioral health? Because the collaborative care model works for the worried well, but we need to talk about who are the disenfranchised, who are clogging our ERs, and who are angry at our staff and don't have primary care doctors because they don't treat people well, or are bipolar or schizophrenic or borderline personalities that don't fit the collaborative care model. We do not have good systems for those people. And those are the ones that also need our help. Thank you.
Thanks, Barbara. Kelsey, if we could just bump to the next slide. So in the spirit of seeding the discussion and talking about our own experience, to Stephen and Barbara's point, my first team-based experience was two of us, and I was working in almost an exclusively Dominican patient population at one of the health centers. And my first team-based experience was with a diabetes nurse educator who was Dominican, from Bani, the city in the DR where almost all of our patient panel was from. And her ability to connect with our diabetes or with our patients who had diabetes was far exceeded my own ability to do that. And we were able to really see some impressive and incredible outcomes on our A1C levels. I offer that as a foray because I think, to Barbara's point, I want to kind of segment this conversation both around behavioral health integration, which I think is a critical component of team-based care. And we certainly heard from all of you excuse me, that you would like to discuss that. But there's a lot of team-based care that is not behavioral health integration and is equally, if not, is equally important to many of our patient outcomes that we're trying to achieve. So I'll open up the floor. We have a few questions on this slide, and there's a couple of questions on the next slide. We circulated these. I think of them kind of in two buckets. This slide really focuses on the what is team-based care, what have you experienced it as, what's worked, what has not worked, and again segmenting that both into kind of general non-behavioral health team-based care as well as behavioral health integration and those models. And to Barbara's point, we have the CCM model, collaborative care model. We have other types of behavioral health integration. The next slide, if you could just quickly click ahead, Kelsey. This is going to focus more on questions around how we prepare future trainees and our workforce to engage in team-based care, behavioral health integration, as well as what types of supports from a payment, a policy, and a regulatory mechanism we need to put in place moving forward. I'm offering kind of all of these at once because I know all of you have different aspects of experience, but would love to center the discussion, at least for the next 20 minutes or so, on experience with team-based care and behavioral health integration, what's worked, what hasn't, what you see as necessary. And then spend more of the second half of this discussion focused on and where do we take this and what do we need to recommend to make sure that we have a workforce that is well capacitated to engage in these types of systems and care models, and what we need from both an education and a training perspective, as well as a payment model and regulatory perspective. I believe Wayne was first, Renee, and then Brenda. Excuse me, Brenda. Wayne?
Thanks, Ryan. This is a great discussion, and it's like such an easy discussion. I feel like we're all so much on the same page with this. Of course, when we have this discussion, I'm presuming that we have doubled primary care investment as we agreed. That's the presumption here. Otherwise, we don't have the resources to do the things that we want to do here. But let's make that presumption that we've doubled, we've gotten to 15%. And this is unlike the patient-centered medical home, which called for this team-based care, but didn't double the resources. This is why it would be fundamentally different than the medical home. I also want to call out the fact that this is the workforce work group, and the primary care workforce is in crisis, is a disaster right now for access and equity for our patients. And ultimately, it's very clear we need to do two things to fix the workforce crisis in primary care: fix the job and fix the pay. And when we focus in on the team-based care, we're talking about fixing the job. So I really appreciate this conversation. You mentioned the three bills, and we've been working on Primary Care for You, or PC for You, for 7 years now. And in that effort, we created a list of 20 transformers, a list of all the things that we thought were really critical to form these teams. And this list of transformers is in all three of the bills. H1370 calls it the transformers. The other two bills call them advanced primary care services. They're all the same thing. And guess what? The Mass Health ACO is practically identical with their list. There's a handful of things that are different in each list, but the overlap is massive, and everyone's on the same page, which is really great. Another point I wanted to make is a lot of people say, well, how are you going to increase primary care access? Not enough primary care folks. People don't have access to primary care. This is a point that Renee has made many times. When you create these teams, you create, and Ryan, you made this point a minute ago. When you have team members who are better at providing services than the doctors or PAs or NPs are, then what it does is when we're going through our day and we hit a brick wall that's going to take hours for us to figure out how to help this patient, we have a team member who will do it better than us, and we don't have to hit that brick wall anymore. And when we stop hitting brick walls because we've got elegant and advanced primary care services as part of our teams, it dramatically will increase primary care access and capacity. I will add two last quick points. You mentioned students and teaching learners, new primary care clinicians moving forward. If we build it, they will come. If we have these teams, all the students will be coming to our offices. They're required to come now anyways. And instead of looking at us and saying, oh gosh, you're all doing God's work, but good luck to you all, okay? They'll see, wow, what a functional environment you have for your patients to take care of them. We want to do this work with you. It will be a complete game changer in how future learners and students perceive primary care. Last but not least, we've had behavioral health integration at our office in Arlington now for close to a decade. We have one philanthropic entity and one startup entity that have provided us with really advanced behavioral health services, both for the worried well and for people who are marginalized and vulnerable. And it's cost us nothing. So the resources are there for people to bring behavioral health into their practices. We just need to move forward with this legislation, doubling primary care investment, and getting all on the same page with team-based care. Thank you so much.
Thanks, Wayne. Renee?
Thank you. And I would have to sort of piggyback a little bit and then expand. What I will say is what's very clear, I've always worked in a team-based environment in some capacity. Um, I also love how a lot of us are talking about our rural history because when you're in a small clinic in a rural environment, my nurse and my MA and myself, that was it. And this was, I have to say, before EHR. And the idea that I had a more solid and coherent team before EHR than I do now with the horrible administrative burdens that EHRs have generated is one of the reasons why we are aggressively pushing towards establishing a way to do team-based care well. When we think about it, the payment reform is critical because without payment reform, the practice redesign is impossible. I mean, the reason Codman's able to do the changes we have with team-based care is because of the Medicaid subcap. If it wasn't for the PMPM, we would not be able to do this. What have we done? We ran a 2-year pilot doing team-based clinical care time is what we call it. And it's about giving the time and space for teams to support providers in the care of the patient. Two visits that are blocked off just to have supported, embedded administrative time. And people are like, oh, you're blocking clinic access. Well, I got to tell you, the team-based clinical care time that we have, every one of those providers have the highest PPH. They have the lowest pajama time. Their panels are larger and they feel supported. And none of them
May have lost Renee. Renee, are you with us? Okay,
I don't want to lose Renee.
we'll get Renee back. Why don't we move on to Brenda, and I will expedite Renee once she's back with us. Brenda?
Thank you. So I just wanted to say, from a team-based care, we do this in pediatrics. It's not perfect, but we really can use supports in ways, specifically with things like asthma education, which the better we explain asthma, which is so confusing because you have to take medicine when you're well, and how to use it and when to do it, limits hospitalizations. And nurses can do this, just are part of our team, which we sort of have, and follow-ups and phone calls after admissions and making sure there's touch points frequently is key. There are other things that we can use other support for in our team-based care, such as lactation, in getting breastfeeding started off right away so that the child has optimal potential for nutrition when breastfeeding is an option. Then also sexual health educators, which again, something that typically nurses can do, but it's important just for prevention of unwanted pregnancies and infections. And then also having access to a nutritionist can help with, in pediatrics and in all the things, but we're always worried about children who have difficulty gaining weight and children who have too much weight and need education in those ways. So those are things that really take a lot of time in the office that can be done by a non-physician or clinician. I personally have experience with behavioral health. What I'll say, overall, as we all know, the demands have increased, and in pediatrics, we've seen a lot more anxiety and depression in the last 6 or 7 years before the pandemic and with social media. And there are not enough child psychiatrists out there to help with this. So what has happened, like our Mass chapter of the AAP has done some continuing medical education in behavioral health, but we've also had to do other things. I personally had to do a mini fellowship in behavioral health just to be able to step up my ability to learn how to prescribe and manage patients in ways that we didn't need to do when I was in training 15 years ago, just because there's not enough people to do it. So we can manage sort of some things, which I think is fair, but I do just want to acknowledge that just puts more burdens on the PCPs because we have to go on and manage things that really are not necessarily fall into primary care, in my opinion, for the more complicated kids. That said, I worked in a system that rolled out a couple of years ago, an integrated behavioral health system, and it was sort of virtual. We didn't have people co-located at my location, but I was in a large system at Atrius, and different sites had on-site behavioral health. So in that system, I'll give you an example of what worked for me and what a lot of the PCPs found very helpful. I was seeing a teenager for routine well visit, and at the office, we send out when they come in I do all my review of everything in advance, but when every patient comes in, there's a questionnaire, and it was the PHQ-9 for the teens. And this specific patient I'd seen had no history of depression in the past, but came in and had active suicidal ideation. And in that moment, managing the patient and trying to manage safety, I had the ability to talk with the patient in bed, talk with her mother, but also what I was able to do was go do a version of a secure chat model, reach out to the behavioral health team, and there's somebody on call to talk with me. I did a full conversation with the behavioral health person who was at a different location, who was then able to connect with the family, assess for true safety, and come up with a plan. And I was able to hand off that patient very safely, so that I could sleep at night. But importantly, the family was safe had a plan going forward with care that they were going to get in person, and also what they needed to know about whether or not they need to go to the emergency room. So I think it can really help just with keeping people in the workforce, because more every day like that, we've all had them, and they just take their toll on our workforce. Thank you.
Thanks, Brenda. Appreciate it. And yeah, I think we've all been in that situation. Renee, I'm going to jump back to you because we unfortunately lost you about halfway through your comment. Do you want to pick up where you left off?
Yeah, I'm going to go off camera because my internet just does not want me to express myself. Okay,
Well, we
so
do. Please
basically,
continue.
the long story short, the payment reform that has happened through the Medicaid has allowed us to make an investment in team-based care. And that investment was, we were able to say, we can't just supply the team, we also have to supply the time for people to do the work. And the time for the work we have put at the beginning of the clinical session. A lot of people were concerned that we would lose patient access because we took away 2 patient visits. What we have found is the people that are doing the team-based clinical care time actually have the highest patient per hour numbers. Their panel sizes are bigger, and they have the lowest pajama time. They're getting the work done. Our mottos are serve the patient, start on time, end on time, do today's work today. And those are that is the foundation that we're using to drive our team-based care. The only way we could have done this is because of the PMPM that we're getting from Medicaid. And I'll tell you that payment reform has led to practice redesign. And I will tell you the next part is the pipeline will fill itself.
Renee? No bother. Okay.
I'm back.
Yep. All right. You're back. Go ahead, Renee.
That do team-based care will attract students in a huge way. Done.
Thanks, Renee. Laura, I know you had your hand up. Did you still have a comment?
No, it's okay. I think we should keep going. I don't want to hold it up. Keep going.
Other comments on the questions on this first slide? Experience in team-based care or behavioral health integration models, what's worked and what hasn't? We can certainly move to the next set of questions. If you could move to the next slide, maybe this will.
All right, that's Laura. I lied. I'll say something.
Go for it, Laura.
Because I have a hard time. So I think one of the things we have to think about with team-based care is the concept of scope creep, which happens very quickly. When you have an individual that's on a team, a social worker, a behavioral health therapist, my experience has been what typically will happen is that, again, pointing back to the administrative burden, you find very quickly that other individuals on the team begin to pick up a lot of unnecessary administrative tasks. So that even pulls away from what the intention of the clinical intention of having that member on the team. Also, I'm finding that we are referring many patients internally for care coordination just to simply walk through the complicated process of getting a referral, getting transportation, and all of those things that should be easy for a patient to do. And again, we're spending time using extremely valuable resources who should be spending time helping patients access benefits that they are able to get, or helping them get connected with the very appropriate behavioral health. I think that's a very good point. There are patients that require substance use treatment, MAT, lots of things that fall outside the purview of primary care. And while a behavioral health clinician is so appropriate for that first line engagement, again, being sucked into having to deliver and having to take on all of these administrative tasks. So that's why typically I say the word scope creep comes up almost immediately when we're building these teams.
Thanks, Laura. Appreciate that. Great points. Stephen.
I'm sorry, but just because Laura put this so well and others, just one example to show a way for us to frame things that might be helpful. As those of us may know, January 1st for prior authorizations being renewed is like Armageddon for many patients. And I have a patient in his mid-30s who has been very stable on an antipsychotic for years and not needed any intensive care. But his antipsychotic was no longer covered as of a certain date in January. He reached out to me urgently, worried that he would develop psychosis again, need inpatient care. He was prepared to go to the emergency room. It took pretty solid work from a set of team members and myself to try to find an alternative for him in the time frame. The suggestions we got from other possibilities were that he should go to an intensive outpatient program or partial program, but he really didn't need those. He needed a medication that had been working for years. And so these are two very different things. I couldn't be more grateful to have a behavioral health team working together and guiding me and patients as to how to help do things. But it shouldn't be because the system is creating an error for patient and putting them in a position where they need to go to the ER and be hospitalized out of concern for their safety. So those seem to me, one requires a team. If the patient had difficulties on his own, we want to be right there for him. But we shouldn't have to keep responding, as folks have been alluding to ways that the system forces us to do things quickly and badly for patients, and we don't have the resources to do that well, and it really hurts patients and their experience. So, thank you.
Thanks, Stephen. Barbara?
I think Stephen has raised one of the issues that we really do need to address in terms of burdens on primary care, which is the prior auth nightmare of patients who have been on very stable medicines for several years. Every January or July, depending on the insurer, we have to repeat the prior authorization. And there is often a break so that the patient needs the medicine. We discover that now it's a new year, they have to get a new prior authorization. And in the meantime, the patient runs out of the pill, not even though the pill may still be on the formulary. And it is an enormous burden that we can fix through legislation. And it is one of the things that we do need to recommend. The other problem is, and for those who know me, I practice in Watertown, which is contiguous to Cambridge and Newton, and we probably have more psychiatrists and therapists per capita than anywhere in the world, and I can't get therapists or psychiatrists because many of them, not all, but many of them do not take health insurance. Yesterday, I saw a complicated woman who's been on very stable meds, for over a year with a no medical history, all psych, who's paying out of pocket to see a psychiatrist to get her meds refilled and can no longer afford it. And, I will take over doing that. But should she run into trouble, we don't have right backup for her. And we need to figure out how to not just encourage primary care, but we really need to encourage how do we get psychiatrists and psych nurses who do meds to help us with some of these more complicated patients, particularly when they're in crisis. Thank you.
Thanks, Barbara. Can I actually ask you, does your practice, I'm somewhat familiar with your practice. Do you guys have mechanisms to work with other people in your system for prescribing, for consult and return to the primary care practice when interruptions like this happen?
We do, but again, it's complicated because there's often long waits.
Yeah.
And it's the wait time that is problematic when someone's in an acute crisis. If they can wait 3 or 4 months, that's great. But if they can't, we're in trouble. Thank you.
Thanks, Barbara. I'll ask one other question, which I'd love to hear anybody else's experience with. Almost 3 years ago now, the state established 27 community behavioral health centers throughout the state, which offer 7-day-a-week, 24/7 access to prescribers as well. I know, Christina, you're shaking your head. That is at least the aspiration. However, that's actually the question is what has been the experience of providers working, if you have experience with any of the CBHCs. And Barbara, to use your example, at least a part of the inspiration of the CBHCs was to enable some sort of safety net system to ensure that there are providers and prescribers who can consult and return and or consult and maintain some of this care. I think this is actually a part of the broader discussion around behavioral health integration. It's not integration at the practice, it's integration at the system level. So I'll throw that out there as another kind of question and foil for discussion. Would love to hear experience with it. I see from Christina's shaking of her head, the experience is certainly, I think, my own experience working with CBHCs as well. It's a growing and evolving system. So would love to hear people's experience. Barbara, if you have any thoughts, certainly welcome.
My experience has been unfortunately inconsistent. So I've had, one patient where it was really helpful and others where it just didn't work. And I'm not actually sure. I'd have to go back and try to think about specifically why it didn't work, whether it was the patient really not able to get there and do the work. Some of it had to do with not having that they were in an environment where they wanted to have a primary care doctor within their system and we were out of the system. That's a real common problem, but I'll turn it over to others.
Thanks. Brenda?
My comment, sorry, was mostly just in pediatrics, we do have something called MCPAP, and MCPAP for moms, which allows pediatricians or providers to get a consult. It's a stopgap, but I realize that in talking about it, it's not quite integrated behavioral health. But in a situation like Barbara's, they can give advice, but again, they're not managing the patient directly.
Yeah. Thanks, Brenda. Laura?
One thing is to consider geography. So my practice is in North Brookfield. Steve, I don't know if you have the same, if you look at the map of where all the CBOs are, or the CBHCs are, like there's this big hole where we are geographically. And so we're in North Brookfield and we have to refer to, I think, Marlborough for Riverside is our technical CBHC through the PCC plan. So I definitely think that there's this just gap right in the middle of the state. The other thing is I've actually had really good luck. We hand our patients, and I apologize, I can't remember the name. There's a card that we got when we joined the PCC plan, and there's an 800 state number on there. We give that to the patient, and then that's actually very effective. I've had a lot of patients who've had good luck with that process.
think you're referring to the behavioral health helpline.
Yes, I am referring to the behavioral health helpline. Sorry. Yes, it's been quite effective. In fact, I had a person I believe I saw her last Thursday, and I got a message from her today saying that she called the helpline. She got some assistance, and she's already set up to see a therapist. So they're very effective.
Thanks, Laura. Wayne?
So when you're in your busy primary care day and you come across a patient who really needs to see a therapist or a prescriber, a psychiatrist, you have that sinking feeling in your stomach like, oh boy, they really need this. And wow, amazing, they're willing to do it. That's great. And then how can I help them? Because where are the resources to find somebody for them? And that sinking feeling I no longer get because we have this startup in our office and they contact the patient within 24 hours and are able to find a therapist or a psychiatrist for them that meets their financial needs, their geography needs, whatever their needs are, through the use of AI. And they have a behavioral health clinician within a week or two and are connected or contacted within a day or two. And it's dreamy and glorious. And so it makes me feel like the resources are out there, they're available, but it's just so hard to find. And so I do think that there are resources that we could access here. If folks want to learn more about this, they can contact me offline.
Thanks, Wayne. Appreciate it. At some point in the next few minutes, and this is not to end discussion on the first set of questions, but I would love to shift the discussion to the questions that are up on the slide right now around both building the pipeline as well as kind of the payment, the regulatory, the policy aspects of things that I think in particular we as a task force would like to consider making recommendations around so that as we look forward to both ourselves in future years, but also the next generation. Hopefully the system is better than it is currently.
Brian, can I just ask one question to the group that I think maybe would help with that transition to the pipeline question? I know I definitely hear a lot of concerns being raised around the systemic barriers to implementing integrated care models in primary care, and definitely absolutely support that and validate all of those concerns. And I guess I'm wondering, I think, I don't know if we've like directly answered kind of that first question on the slide, which I think maybe is important to answer before moving into the pipeline of who are we trying to recruit and get to be able to build these primary care teams. I guess I would ask to maybe put the larger systemic issues aside just for a moment and to think about within primary care and thinking about the challenges that I think Laura in particular raised around scope creep and kind of this extra administrative work and things that ideally we'd like to see be able to happen in the primary practice with a fully integrated care team. What does that look like? What does the ideal care team look like? Do you have clinicians and prescribers on staff? Do you have more entry-level roles, community health workers, peer navigators who are able to do the more administrative work? I heard mention of folks who are dedicated to looking at inboxes, but just wanted to put that question out there of like, what is the team we're trying to build here in kind of this ideal scenario?
Work, Sam.
My comment is not about that last comment, so apologies. I was just something I was thinking about from the last conversation, and this may sound super silly, but in terms of identification and accessing needed appointments with the right clinicians, I don't know if anyone has personally used ZocDoc. But I have to say, from my family's experience using it and accessing different type of clinicians, and I just did a quick search on psychiatric services in or near North Brookfield. It gives you a list of providers and their schedule and their openings by time slot. I'm not saying it's a panacea, but it may be something that's worth looking at to see if there can be a push in Massachusetts to have greater linkage between schedules and ZocDoc as another complementary method to assisting caregivers, teams, and patients access needed care.
I'm sorry, it's Laura. Christina, that's a good, when you go on ZocDoc, does it say what health plans that the providers accept?
Yes,
It does.
yes, it does. Yep.
Great. Thanks, Christina. Wayne?
Yeah, just to piggyback on what Christina said, I think it I think it speaks to the fact that there actually is access. There are resources out there, but it's very difficult to find them unless you utilize something like ZocDoc or something like the AI company that we've been utilizing that helps find people so quickly. So without too much difficulty, we could leverage these resources and get our patients access to this really critical care. The other thing I wanted to say, I mentioned there was one startup and there was one philanthropic entity. There's a billionaire who lives in this state who has started up a foundation that is dedicated to behavioral health, but specifically workforce, building a workforce in behavioral health. He actually has become a part owner of the Celtics. So in my book, that makes him great. And and Ryan, one of the questions here is how do you get started? What is required to help people get going with this? And the biggest challenge is activation energy and activation cost. These things can pay for themselves and often can actually be profitable, but not in the first year. There's energy and cost associated with getting it going in the first year. Well, when you have the transformers and you double primary care investment and you give people resources, it generates some of the money that you need for that activation cost. And some of these philanthropic entities could help with activation energy. When this person contacted me for the first time about working with our practice and said, we will help you staff your office with care navigators, who are probably the most important person, bachelor's degree level people who get everything started in cooking. Okay. We'll staff you with care navigators and therapists and a psychiatrist 1 hour a week to be a consultant for the cases and so on. And we'll pay for everything. You don't have to do anything, and we'll teach your staff how to do it. And I said, how could anyone say no to this? Yes, the answer is yes. And he said, you're the 10th person I've talked to and the first person who said yes, because everyone is so overwhelmed in primary care getting their prior auths done that they just don't have the mental capacity for one more thing. So if you help people with that activation energy and the activation cost, it'll help get things going, I think.
Thanks, Wayne. And I'll just add, I think from the Mass Health experience, we, as others have alluded to, and many of you have practices that participate in our subcapitation program, the activation energy and the resourcing and the effort that it takes to actually engage in these systems is not inconsequential and absolutely should not be underestimated, both from the provider and the practice perspective, but also from actually staffing up and building the systems and the workflows and the processes that are required to engage in these team-based models. It is not inconsequential. Totally agree. Stephen.
Just really
Yes.
really quickly, Ryan, one super quick, sorry, Steve, if you ask a primary care practice to find people to staff their office, you go hire a care navigator and hire a therapist, that they're going to say, I don't know how to do that. I can't do that. But if you say, we're going to hire these people for you, we're going to staff you up with these folks, you just need to provide them a small room in your office to sit there and be embedded in your office, then people will play. Over to you, Steve.
Thanks, Wayne. Really appreciate it. And thanks for this line of question. And Amy, just to a slightly different framework, but that comes from patients also. What is necessary and sufficient for a workforce is trust. And the evidence is crystal clear. People do not go, especially for stigmatized conditions, to people they don't trust. Full stop. And what I've been grateful to learn over I think the most revolutionary change in the field in the last quarter century is the advent of peer recovery specialists and peer specialists. I mean, this is very not glitzy, but one of the most meaningful roles that patients have ever had in their lives is someone who gets where they're coming from, who they can trust, who meets them where they're at, who texts with them, who gets that their voicemail doesn't work, who knew where they grew up. It's old school stuff, but we're so lucky in Massachusetts to have had brought that along and fostered peers thanks to very smart policy work. And we should do it even much more. This should be a sort of a regularized part of the team. And so I hope that addresses one of your question, Amy, in terms of who would be helpful to have around. It would be fantastic, just fantastic to have more peers doing the work with us.
And Steve, when you walk your patient down the hall and introduce them to the behavioral health professional, the trust is instant.
I couldn't agree more. No, it's very present, and thank you. Please bring trust on board as a necessary part of things, and how can we foster it? So thank you.
Allison, go ahead.
Just a comment. I mean, I think the one thing that I'm feeling like I'm hearing over and over is everybody's doing it differently. Like everybody's having to navigate stuff. Everybody's looking up, how do I find this person in my community? Like there's no, not that it's a one size fits all, but like, we have, it just seems like everybody's having to do their own work to navigate this. There's no system in place to say like, this is, what we're going to help with overall. Maybe that's where we need to start, and kind of answering Amy's question of like, what do these care teams look like? And then how do those resources trickle down to these practices? Because I think the amount of energy, like Wayne was saying too, of just trying to get things up and running is immense. And that kind of, puts people in a position where they're like, I can't do this, or I can only do it minimally, or so it's just like one more barrier, just like the prior auths. It's like one more barrier, one more thing to do, one more stopgap. So it's just like listening to everybody, everybody's kind of navigating it in a very different way. And it just seems like it's a lot of wasted resources for clinicians to be doing this.
Thanks, Allison. Their comments, and I'll loop back to Amy's question. Maybe you want to take a stab at Amy's question? What are the roles that you would love to see in your practice, for example?
I'll take a quick stab before my internet disappears.
Go ahead, Renee.
So what I would like to be able to do is hire the team that is appropriate to my local environment. That's going to be different for different folks. Where our challenges currently is MGB and BI get paid more for that one visit than I do. So I can't compete with them to make the teams that I want in a sustainable way. So it should be hyper local based on the needs of that clinic. And if we had the ability to compete for the same people that MGB and BI does, excellent folks could be all across the Commonwealth, not just being hoarded by the folks with the most money.
Thanks, Renee. Go ahead, Laura.
Renee, you just made a fantastic point. Again, it's small practice, independent, not tied to any specific group. I have an extremely complex, high need population. I can't afford to pay. I can't even contribute to health insurance. I can barely, granted, it's only been about 2 months that we've been open. Worry if I'm going to make payroll every 2 weeks, and having to potentially take out personal loans to keep something like this going. The practice had to close because the reimbursement was not enough to cover the need. And I think that, again, granted, we are fee for service, but and we are coming up with some ways to generate some additional revenue through participating in the PDCM program through Mass Health. But again, it's just, if I can't even afford, I can't afford the people that can make the biggest difference. And I'm not talking about high dollars here. I'm not talking about a provider. I'm talking about, a community health worker, somebody with lived experience that really, as Steve had said, builds the trust with the patients and are immediately develop these incredible relationships that can make a big impact on and great impact on outcomes. And so whether or not it comes down to reimbursement or just level the playing field for all of us who are trying to do really good work in our communities so that we have the same opportunity and we have are able to hire high quality people that are going to make a difference for our patients.
Thanks, Laura. Go ahead, Barbara.
I think that it goes back to what I said in the very first statement, which is that the model is really wonderful to pay primary care doctors more and to pay more for team-based care. But is the model, paying enough so that groups like Laura's and health centers like Renee's can actually provide what they need? It certainly is better and moving in the right direction. But what we really are asking for is we need consistent people. I want at Mount Auburn, my IPA has provided social work and nurse case management. And I'm lucky enough that, the nurse case manager that the IPA has provided has worked for us for many, many years. So as I've grown older, my patients have grown older, she knows them, the ones who are really ill well, knows their families, and can really have a major impact. And in order to do this in a global, statewide level, we want consistent care, and we want to be able to pay people enough that they want to stay with us. And I think at the end of the day, we know what we need. The question will be, how do we get the money to really put it into the various types of offices that we want to support? Because we need to, at the end, we also want to make sure that all of the private practices, which are out there much more isolated than those of the employed groups who are being in health centers, that they can really survive and get the resources they need, because their patients need it as much as everybody else's. Thank you.
Thanks, Barbara.
Just one other quick thing regarding Amy's question. I'll double down on care navigators being the real key and being able to have people embedded in offices who are care navigators and to augment the workforce of care navigators. I think it won't be too difficult as long as you pay them a reasonable living wage. If you pay people, they'll come. If you continue to pay people next to nothing, the workforce will continue to suffer.
Brenda?
Well, just piggyback on Wayne's comment, I've worked where we've had sort of care managers. I've not found them very effective. I just think they need a little bit more training, and that might also come down to compensation as well.
I'm going to go back to something Wayne, I think, said a few comments back around activation energy. I think it was the term used, Wayne. And I'll point to the last question on the slide currently. So let's talk about what practices or systems, but would love to hear at the practice level need to do more of this. I think the activation energy, Wayne, is a salient point. What does that look like to actually, for those of you who have started or have worked in team-based environments or have team-based environments, what did that look like practically to get that off the ground? And what were there resources that were available to you through your system, through quality contracts, value-based contracts, through philanthropists who own part of the Celtics, if you're Wayne? Steve?
No, thank you. And this is such a salient question, Ryan. And something that I've thought about, and I think we all have, is a primary care team is not one thing. And to keep the professional sports, comparisons, the Patriots last season were a team. The Patriots this season were a team. They had the same number of people on the team. They had the same roles on the team, but they were very different in their success. And what I'm struck by in the way that we've thought about primary care teams is my sense is we tend to put them together and then we just sort of let them believe that they're going to sort of just work on their own. And there's no ongoing teamwork. There's no coach comparison. There's no, are we doing better, worse, the same? There's very, to my knowledge, and this is from several systems, it's just not fostered the kind of really hard work it takes, the hard work it takes to have teams work well over a long time, especially when they're not continuous. So, I mean, we don't have to look very far from middle school lab, groups to current groups. Like, it's hard to work in a group, and it takes effort and some knowledge and ongoing investment to help the team. So it may seem very simple, but just we need care for the care and feed. There's a famous article, The Care and Feeding of the Medical Student, I think, but we need care and feeding for primary care teams so that they can operate, they can work their best. So thank you.
Steve, I believe your practice, I believe you said at the beginning, you guys do have somewhat of a team-based structure. Can you speak to, were you around when that was first launched and kind of what that took?
Well, we have an integrated behavioral health structure for sure. And that's been extraordinary. We, as everyone has mentioned, we suffer only because we can't hire enough people that we need. And we've had to push pause. I mean, when we're not talking about this, but we've had to put pause on internal referrals for primary care, for behavioral health, because we don't have enough people to do the work. And so that's one element, Ryan, for sure. I think there are certain policies that I don't understand. Our medical assistants can't give vaccinations, for example, for some policy reason. Like, there are all these sort of ways that the organizational structures and protocols don't allow the team to work as optimally as they could. And I also, we never really had a conversation, to my knowledge, with management about what would we really find helpful, what do our patients really find helpful. We're just sort of given a structure and then wind it up and let it run. We truly, and to my knowledge, I've asked about this, we do not have an ongoing training program for outpatient primary care teams. And that just seems, a real absence of something that seems essential to me. So thank you.
Thanks, Steve. Christina?
Thank you. You all know that I work with federally qualified health centers, and it's kind of ironic, but it's healthcare, so it's not ironic that health centers, which are so underpaid by commercial carriers, get fairly paid by government, because the way that government is financing it is not subject to all of the forces of healthcare, quote unquote, free market. And we all know that when healthcare is in a free market, it is incredibly dysfunctional and behaves in a way that is opposite of how a free market is intended to behave with supply and demand. And that is that the more expensive providers get more for being more expensive, and the less expensive providers get less for being less expensive. And so, to Renee's point earlier on this topic, you get a commercial carrier taking money out of the neighborhood where Renee works, South Dorchester, and moving it to the Back Bay, because that's how it behaves in a free market. Because health centers have the luxury of doing a lot of business with state government, and that is matched by the federal government, so I'll say governments, that have been able to go further. It does not mean that every health center is the same, and it does not mean that it's perfect anywhere, on becoming truly integrated, so that it's not only about care coordinators and care managers and social health workers and peer support specialists and recovery specialists and family specialist, but it's also defining primary care as physical health, behavioral health, oral health, and vision health. So that I think when we talk about an integrated care team, it's we tend to center around the prime physical health, but I think it's also worthwhile to pull that back and say, should we center on the physical health? Or if we're talking about team-based care, are we really talking about all of the components of a person's body? Thank you.
Thanks, Christina. And despite the fact that our medical education system decided that the mouth and the eyes and the ears are somehow not a part of the body, they actually are a part of the physical body. Anyways, editorials aside, Wayne, over to you.
Yeah, I agree with that, Ryan. So I appreciate Steve's Patriots metaphor, and I think that you could argue that part of a primary care clinician's responsibility is to be that quarterback, to be that leader of the team, to be that person who fosters excellent teamwork and team function. With that said, there's some who are better than others. There's some organizations and some PCPs who are better than others at fostering those teams. And so there'll be some practices and systems and PCPs who will need some help with best practices. So in terms of a concrete recommendation from the task force, I think that part of what should be in legislation is established as part of some sort of primary care body. And of course, I've talked about a primary care stabilization fund. As part of that primary care stabilization fund or primary care body, there should be an entity that is there to help support practices who request support and provide best practices to the folks who are looking for that help.
Thanks, Wayne. Other comments? Great. Well, this has been incredibly helpful and insightful, and I want to thank everybody for the perspectives on this. This is, I would say, one small sliver of broader workforce challenges, and I know we have more discussions to come in the coming months, and so we'll be certainly revisiting these as well. So,
Ryan, did you hand it to me?
yeah, sorry, over to you, David.
Yeah. Thank you, workforce members, workforce work group members. Thank you. I really appreciated this robust conversation, and I think zooming out as I think about our recommendations and I think about all of these pieces coming together, I think about the recommendation that we put forward as a full task force, doubling the share of medical spend on primary care, and how that alone doesn't do it, right? We need to have payment reform. We need to change the way that we're paying for and supporting primary care, and in so doing that, and Renee, you kind of said this, payment reform is critical to practice reform, and then that practice reform can unlock what we've just been talking about today, and unlocking really kind of this ability to do the care teams and to do it in different ways, and maybe reflective of your own communities or your own patient needs, but that this idea of this team that can be a kind of a force multiplier of primary care, and Renee, you kind of talked about it, this ability that in your experience where even though, kind of you were taking some of the time away, you were increasing the panel size, right? And it's not just increasing the panel size, you're also reducing that burnout, you're increasing the satisfaction and increasing that, the interest in continuing to play in that role and to serve in that role. So it creates this, kind of expansion of capacity just in doing some of these different steps. And I guess the last piece that I think about is even with all of these steps, there's still some administrative stuff that we have to fix. And if we can do that too and get rid of some of the day-to-day things that don't need to happen, and make that all the easier, that can be another area of kind of another force multiplier. So I think we're going to continue to think about how these pieces fit together in terms of our recommendations as a full task force. We are going to be meeting as a full task force in a few weeks. Our next scheduled meeting is March 4th. We will be in touch with you in terms of whether location, whether we'll do that virtually, and we'll be in touch with you. We do think that there's probably definitely some more conversations that we want to have with this workforce work group. But we want to hear from you all about what specific topics we want to spend our time on. So all of that is to say, we'll be back in touch with all of you. And thank you so much for the conversation today.
Thanks, everybody.
Thank you, guys.
Thanks so much. Be well.
Good meeting.
Thank you.
Thank you.